Guthrie for
Thank
his
you very
5
much,
minutes.
and thanks for everybody being here. Thanks, Ms. Wilkes, for being here with your story. And it's kind of frustrating. It gets to a kind of a larger thing. I'm on oversight and investigations. We're looking at insulin pricing, and it kind of looks at the difference in net price and list price. And it seems here, I have an instance. We all have instances in our area. Emergency situation wasn't emergency room physicians, where a person in my district who's actually an insurance broker, so he's very sophisticated, talk about insurance literate, had an emergency situation with his son and was billed over $30,000 for a service. And if he had an insurance had been a network, it had been less than 10. And he actually sat down, he wanted to, they would refuse to do it, said, if you'll sit down with me and show me your price and your charge and some kind of reasonable return, I would pay it, but they wouldn't sit down and go through their price and charge. So that's just a big issue. So I'll write you a check today if you can show to me that that's really part of it. And that's what's the problem that we're getting at, just the overall system here. But Mr. Gelfand, getting back to the notice of out-of-network, in your testimony, you mentioned the need to tighten the requirements in the discussion draft on patient consent for out-of-network procedures. Could you elaborate what you think this should be?
Yeah, we associate ourselves with the remarks of Families USA that you cannot simply give 24 hours and allow the physician to surprise bill as long as you have 24 hours notice that a surprise bill is coming. Because oftentimes you may be going to a facility, but you literally have no choice about some of those ancillary providers that will be present at that facility.
So it gets to Ms. Thornton. Ranking Member Walden said that the person asked about, is the anesthesiologist before I signed this form in network, and the provider there didn't. I'm sure it was a gastroenterologist or whoever was doing it didn't know. I mean, how do the health insurance plans fit into notice? We're trying to figure out how this would work. Somebody walks in, I need service. They're in or out of network. How do we know? And how would the health insurance plans be involved in this?
So in the first place, it's important when you have an emergency or you're at an in-network facility, patients are protected, right? This federal law would sort of swoop in, so we wouldn't have situations where consumers are getting that bill because they would be protected by the payment benchmark that we're talking about today. Now, in scenarios that aren't covered by the bill, we do think there is an important role to get notice, to be able to call the health plan and say, hey, I've got this procedure next week. Can you let me know, what the network status of my provider will be? And we think that process can work for more things that are scheduled in advance and not emergency care when you have no control over who's going to see you and you're in no position to have that discussion.
Well, it can't be just in the emergency room because Ms. Wilkes she was in a labor delivery room, I assume, and next thing you know, you're in a NICU. So, I mean, it's not just in TALA type of situation. Exactly. I understand that, we talk about just don't look at unintended consequences. We just have to move forward. But it is an issue with emergency room physicians because they have to take care of it. They can't talk about price, and that is different than other things moving forward. I do have a question, Ms. Thornton. You're subject to the medical loss ratio. Requirements, and those are requirements that require minimum percentage of premium dollars taken to be spent on paying claims. Can you speak to how an arbitration system might have an impact on MLR requirements?
Sure, happy to do that. So there are two different components of a medical loss ratio, sort of what we're spending on medical care and what we're spending on administrative costs. On the medical cost side, it's really important here that any solution that we're talking about to end surprise billing does not increase medical spending. That $30,000 bill that you mentioned, right, that's reflected in people's premiums that they pay every month for coverage. So that's sort of one piece. But on the other side, if you're taking a kind of a bureaucratic process and inserting it into the healthcare system, Dr. Friedman mentioned 150 million ER visits a year. Even if you took a percentage of those and threw that to arbitration with those administrative costs, that would be adding a lot of costs to the system.
So we would have to, your argument would be that we'd have to take that out of the medical loss ratio calculation? It
would be administrative costs borne by the health plan, yes.
Okay. So this really isn't for everyone, but I just have less than a minute. But so once a bill is put into place, becomes a federal arbitration system. What do you think congressional oversight should be? And I don't know if that would be something Ms. Wilkes wants to talk about or.
Well, I've been sitting here listening, thinking, I pay my insurance premiums, I do my part, and I expect the bill to be paid. I mean, there's only so much I can do to control that. I don't really care how the reimbursement works, and quite frankly, I think the insurance industry is doing probably better in their bottom line than my bottom line. I want to go to the best provider possible, and I want the best care possible. I don't really care how the payment works.
Okay, thanks. And I won't go on down the list because my time has expired, but I do hope things are going well. And our other part of our area, we're looking at genetics and things like that, and some really great things that are happening in hemophilia. Hopefully your son will qualify for those as well, as his genetics will qualify, not just your insurance. Your genetics will qualify is my point. Thanks, appreciate it.
Gentleman yields back.